Hello, good afternoon, each and everyone present over here. I would like to say, develop a passion for learning. If you do that, you will never cease to grow. And ANEI will take you from the passion to action. This is the association, the only association I can see and I can feel, I can experience since 2017 that it has started, that I am lucky to be the founder member. I'm fortunate to be the vice president of Association of Nurse Executive of India. So Professor Dr. Unmona Borgohain Sekia would like to welcome you to this Empower Hour. This hour dedicated to our nursing profession, to enlighten for the future generation. And we are handholding our young professionals in terms of education, practice, and research. And ANEI constantly engaged. I can really say that none other organization is so connected, so involved, and throughout the year, all the activities on the roll. So we are happy to be part of it. I'm sure the who are not members in this ANEI, if you join, definitely will be glad to be part of it. And you can contribute to the profession and contribute to the healthcare industry. And particularly for last 2 years, Madam Thankam Gomez, who is the founder president and who conceived the idea for association, and particularly for Empower Hour, for 2 years, she was doing marvelous. And we are this year focusing on purely on the patient's perspective. How the patient feels, what are their expectations? Because ultimate our purpose is to heal the patients, to care the family, to comfort them. This is our purpose. This is our service. So with this, we have started this Empower Hour with this theme in 2024 January. And particularly this year, sorry, it's not moving. Okay, this month, I can say the center is taking up, that is the Delhi, that you can see this flyer over here. All the members, Professor Ramindra Kalra will introduce later on. And I just would like to tell quickly the 2-3 slides from our ANEI. Our vision is to provide leadership, professional development, and research to advance nursing practice, nursing education, patient care, while contributing effectively towards India's health goals. Mission to work with all stakeholders. Even when we are having the conferences, we call all the people from the diverse discipline. In establishing a national system for improving the nursing scenario across India, thereby impacting patients' safety and clinical outcomes in all settings of healthcare. As we know that we have so many chapters already included from the different states in ANEI. Okay, and there is a link I'm showing you over here, www.anei.in. If you go to that website, you can see the kind of people are involved, kind of leadership we have, kind of training we are providing, and activities what is going on. And you can also enter and register by yourself who are still not members. And I'm happily and proud to put up this picture, founder member, founder president, Madam Thankam Gomez. She is we cannot think of ANEI without her. Okay, she's always there. She's with us even now. Madam Jyoti Clara, founder, national vice president, and Madam Subhada Sakurikar, founders, national secretary, and Captain Ajitha Nair, founder, national treasurer. Who are the people who work very hard and establish the route, and we are growing now on from that route. So currently, we can see the current national officials. Madam Ajitha Nair become the national president. I, Dr. Unmona Borgohain, is the vice president. Dr. Vinci Tribhuvan is the ANEI national secretary. And Lieutenant Colonel Dr. Aji KL, ANEI national treasurer. So this way, we are having the Empower Hour every month. And we are at Delhi now. And next will be Telangana by Haritha. Okay. So I don't want to talk about the patient safety more about this. These are the few things I thought to highlight, but I look forward for the discussion only. And but before that, before I go off from the beginning, I would like to tell you one information, very informative information for you. Patient safety conferences by ANEI is going to held on 27th of September. Please block it. This is in the beautiful city, Bangalore. MS Ramaya College of Nursing is organizing and they are ready to welcome you all. Please block your date and attend the same. You can learn a lot. So with this, I just would like to stop the slides over here, and I would like to invite Madam Ramindra Kalra to take over the session and to go ahead by introducing our esteemed panelists for today's. And all the best, and thank you very much. May I invite Madam Ramindra Kalra over here?
Yeah, thank you so much, Dr. Urmona, for introducing Annie and for introducing the today's Empower Hour. We are privileged to have this, we are privileged to have this being organized by Delhi chapter. In Delhi chapter, Captain Sandhya Shankar is the president. She's not able to join, so this responsibility has been entrusted on me. As you said, Empower Hour have been arranged from last 1 year, and this year we are focusing mainly on patient engagement for patient safety. WHO has initiated a decade of patient safety 21-23 that engages the and empowers patients and families and facilitates their partnership with health professionals and policymakers to make health services safer worldwide. And we know that it is the patient who's there throughout. Patient is the main focus for any healthcare services. The emergency department is the first point of contact for any critically ill patient needing immediate medical attention. There may be certain patients who may not be so critically ill, certain patients who need really immediate attention. So triad is being used, and many times it happens that those who are not so sick, if their treatment is delayed, they feel I'm not being given the importance. I'm also suffering. So there are different challenges, and we are privileged to have today in our Empower session being discussed on patient engagement for patient safety in emergency department. And for that, we have Mrs. Topsy Bhatia, who's the patient, who will be the voice of the patient. She has been patient, and also as a family member, she has been to emergency several times. We also have with us Dr. Divya, Head of Emergency Department, Holy Family Hospital. She has got vast 15 years of experience in emergency department. Then we will also listen from Vipin Peter, who has got 11 years of work experience in Fortis Shalimar Bagh as the nurse educator. He has a senior nurse educator there, training the nurses, because when they train, how to receive the patient becomes one of the very important aspects of training. We also have with us joining Colonel Sandhya Nair with vast 29 years of experience, who is the nursing superintendent and head training and development Medanta Hospital. So I'm sure that this discussion will really be very useful for all of us. My one request to all the participants that whatever questions are there, whatever are your suggestions, please put them in the chat box. We'll be taking them in the end of the session. And thankful to all the participants who have joined for this Empower session. Now, my first question is going to be on Topsy, because patients are the focus of attention. I would request Topsy to kindly say briefly about herself, her illness, and her experiences in emergency department as a patient. Over to you, Topsy.
Thank you, Dr. Kalra, and good morning and rather good afternoon all. and it's a great pleasure to be here amongst all of you. And I feel quite responsible for being the voice of all patients because I'm representing all the patients. And of course, I would also be speaking from the perspective of, an accompanying attendant because it's both ways that it works. Well, I have been a patient rather during the COVID time. I went through a very bad phase and visited many hospitals and some good experiences, some bad experiences. I would not like to name any hospital, but yes, I would like to share the experiences here. And the good experience, if I would say in particular hospitals, like I said, I would not be naming, was that I got immediate attention. The doctors were there to kind of, they had that connection with me, understood my problem, and also were quite receptive to my attendant. Because you see, when a patient is coming to the hospital and is coming to an emergency room, he's already very critical, right? And even if he's not critical, but the mind, mentally, he is very critical. So physically is one thing, mentally also is critical, and also the attendant who is accompanying along, the family member, I'll call it the attendant, who is accompanying along, is in a worse situation than the patient. Reason being that he is like putting the patient in the hands of the doctor, and then he's probably asked to go out, and then he doesn't know what is happening inside, you know. So that is a very critical thing also for them. So I would like to say a few things that I feel that I have probably have maybe not myself many times, but yes, of people I know. And I've seen also for myself that a few things that I would like to definitely share is that when we are coming to the emergency, we would definitely like, of course, COVID time was an exceptional time that we had, and we were short staffed. It was all over. But otherwise, I'm not taking the COVID part. Generally, I'm saying that when a patient comes, so it is as per the critical situation that the patient is taken in, attention is given. There are times when I've seen patients who are not critical, so they are kind of ignored for some time. Even if the staff is there, attention is not given, whereas the staff is still available and can take care, you know. So that I think that's a big gap that has to be filled up, if you ask me. And also, a doctor is coming or a nurse is coming. Most of the time what happens when the doctor comes, he is hardly having a eye contact with the patient. He is only talking to the nurse, attending nurse. Okay, what is the situation, right? What is the immediate action taken, or what is their diagnosis? Instead, it would be nice if the doctor would also talk to the patient and understand, give an eye contact, some kind of empathy, that works a lot. Because most of the time you're not even giving eye contact. Have a personal touch, a personal relation, because a patient has already come with mentally very weak at that time. Acknowledge the patient, acknowledge the problem, talk to the patient, get a little personal, you know. So I think that connection is very important, so that the patient also feels I'm in the right hand, or I'll be fine, right? Though I know I will be fine, but there's a way of kind of coming to it. So that will help a lot. And if I talk on the part perspective of the attendant, the attendant is waiting outside. The attendant knows nothing what is happening, so most of the times he doesn't get to know what is happening inside. And it will be nice if someone goes out, and if the doctor also goes out for just a minute, just to inform the attendant that, look, this is the course of action is taken, this is what is happening. That is satisfies the person. And even I would like to also talk from the perspective of the attendant, that they don't even get a chance to, they don't have a proper place to wait. That is equally important. They don't even have a sitting area outside. Because, it's like I said, it's worse for the attendant. Patient ko to ho gaya, the doctor is there to take care. But what about the attendant who is pretty tense outside, right? Who doesn't know anything. So a little, see, the whole thing is getting a connection with the patient, giving eye contact, some empathy towards the patient, not always being professional all the time. Fine, you have to be professional. It's a tough job for the doctors and the nurses, completely understand. But an emotional connect with the patient will go a long way. It will go a long way because then the patient will also calm down. I think it will reduce your work by half. This is my mindset. This is what I feel. Main I would say is that.
So, good afternoon, everyone. This is Dr. Divya Sinha. I'm going to take over from here, Mrs. Bhatia. I really appreciate the time which you have taken out and your inputs which you have given to us, because that gives us a fair idea about what the patient feels. We completely understand about the situation, because per se, when you say about communication, that is one part and the most important part when you're coming to the emergency, and the communication happens with via both the parties. Okay, now when we are talking about emergency department, usually what happens is that the patient has been brought in. uh, Either the patient is conscious enough to give the history, or the patient is in a very critical zone. Okay, in both the cases scenarios, it is always an ideal situation to have an emergency department would be to have one attendant at the bedside of the patient, so that the patient is comfortable and the attendant is comfortable.
Absolutely. Absolutely.
That gives them an idea that they are not lost and somebody is there to take care of me, because obviously in emergency, the emergency door is open for all the people 24/7. So you might have 5 patients at one point of time, and you might have 50 patients at another point of time. There might be a surge of patients which are coming in, and they cannot be denied the care. Obviously, based on triaging, we have to start seeing the patient. Okay,
Also,
for
one point I'm sorry I would wanted to add here is
yeah.
that also what happens is the treatment gets started without even, informing, because it's happened with me. This is my personal experience I've had. Okay, I've been taken into emergency, treatment has started. I'm like, what are you doing? Can you please tell me? Fine, I may not be that critical that I am conscious. I'm conscious enough to even understand that what is happening to me. Can you tell me what are you treating me for? What is your diagnosis? What are you giving me so many injections for? What is this for? So, most of the time that is not told to the patient or to the attendant
I,
who
I
is
totally
standing there.
agree. So,
Yeah,
there is a saying which we have been learning from our, school days, that first impression carries a lot of weightage.
yeah,
The
yeah.
moment there is an impression which goes on, ki fine, they are going to take care of me, and the ease has been maintained, the half
Hmm.
of the problem is solved. I totally agree
Yes,
with you. Acknowledging the patient is absolutely important. Apart from not only acknowledging the patient, including the family, that yes, I've seen your patient, this is my plan of action, and this is what I'm going to do for your patient. We're going to wait for the
absolutely.
reports and we are going to come back to you. So communication, basically, if we know, it is a Latin word which has come from the word communicare. It means that there is a sharing of information. So when you have a sharing of information, it is via sender to a receiver. And when we are talking about sender and receiver, obviously it has to be a two-way communication. If it is a one-way communication, either way, the patient will be not satisfied or doctor will get half information. Okay. So when you come to the emergency, obviously most of the time what happens is, once the patient is triaged and the patient is in a status to give the information, usually the doctors uh, will have to spend time to take out the history and examination. Otherwise, they will not come to the proper diagnosis. You can't just give blindly drugs to the patient stating कि ये आप इससे आप ठीक हो जाओगे. We are not living in that era anymore, where you just go to the doctor and you start the IV saline and you say I'm absolutely fine. Also, being the face of the hospital and the first contact of the hospital, emergency department holds a very important place, not only in from the patient's perspective, also from the administration perspective, because we are definitely going to be the representative of the hospital. See, the whole hospital is shut down in the evening time. It is mainly the emergency which is going to be open. So you have any queries, any doubt, it all comes down to the emergency department. So we always tend to do this common mistakes of not taking it as a vicarious responsibility. Now is the time when we are going to have it as a vicarious responsibility. Fine, the onus comes to somebody and I'm going to be the representative of it. That responsibility has to be taken. I acknowledge the point that acknowledging the patient and accepting the faults, especially when there is a delay for any particular reason, and most importantly for any conscious patient. Okay, tendency is that if the patient is not speaking, the doctors and the nurses are by default going to turn that way, that why this patient is not speaking, because definitely that patient is critical and does not have a voice of their own. But when the patient is absolutely conscious, oriented, and is in a state to understand, it is the responsibility of the medical staff and personnel to have a discussion, put their views across, let them know what is going through and what is their plan of action. If there is a missing link in that, if there is a miscommunication, we are not informing, there is always going to be a dilemma which is present in the patient scenario. For example, the patient comes inside and he enters the emergency department. He is not aware where he's supposed to go, which zone is he going to be triaged into. And if he enters and the moment he enters, he has been told that you have to go to what is your problem and can you tell me what is the issue. He says, I'm not sure what is my problem. I have come to show somebody. So you should not be standing here. You should be going to the green zone. Now that's been told. Saying so, the patient who's entered is right now in the dilemma, where is the green zone? Before he could ask anyone where to be guided, he has been asked to go to a place which he is not aware of. So till the time he reaches there, we have to understand the mental level of the patient. He has already been created a doubt in his mind. I have come here to show myself. They are not interested to look into me. She's not interested to know why I came here. And I've been guided to the green zone. Why am I guided to the green zone? What does the green zone stand for? People are not aware about the triaging system. We are. Okay, we have developed the system. The patients and attendants have not. So obviously, one word of acknowledgement and information solves a lot of problem. Then comes the most important part is that when the patients are with us, we have a lot of scenarios going simultaneously. I might have absolutely stable patients, lying down, which might be 15 to 20 in number, and I might have two critical patients. But those two critical patients, if not given attention, will lose the life. So obviously the priority goes towards them. That does not indicate the remaining 15 are not important. And that message needs to be disseminated equally amongst them. So if we have to, make an ideal emergency department, it should be divided zone wise. The zone wise clarity has to be there, and one person at the entry should be there to inform them why you are being taken into this zone. Secondly, once the area has been divided and you have been there, the distribution of the assignments have to be such that in the non-critical zone also you have nurses who can communicate, you have doctors who can go and discuss, and you have counselors who can counsel the attendants that what is going on with the patient, apart from having counselors in the red zone area. Most importantly, what link we have been missing in an Indian setup scenario is mostly they don't have a counseling room. So it becomes an open space discussion. Attendants are most of the time not comfortable knowing what is happening to their patient in front of 20 other patients. Especially, I tell you for the examples where there are young patients who have been through depression, they might have hanged themselves up or they might have taken some overdose. They might be critical, they might not be in a critical zone. But when we try to discuss out at the bedside or at the side where the doctors are sitting at the counter with the other relatives standing, I have seen personally the eyes which says that I'm not comfortable. I want a space. I don't want this open discussion. So we take the initiative. Ki fine, you come here. We will discuss it in this room. So one area of focus should be looking at into the counseling room, because that will solve a lot of problem. Having counselors in the emergency department will solve the problem. But again, that is going to be an additional cost which we are talking about, which the management will have to look into. In today's practice, patient safety is one of the most important pillar. The whole quality department, whole hospital has been standing on the lines of patient safety. We have multiple parameters, clinical audits, which we are conducting to make sure that the patients are safe. You document events, you document adverse event, you document incidents. These all are for the patient related services and to ensure that the patient does not suffer any of the policy related or a delay in treatment which will cause harm to the patient. So now the practice has been changing from the beginning where we used to deliver the care. It is not only deliver the care, but the basic rule of what Hippocratic oath is, do no harm, is being taken into consideration, and a lot of emphasis is given on that. When you come to the other points, which I would like to discuss most importantly is the sensitive communication. As I told you, an open space communication is an issue. The other issue which mostly happens is the critical patient being brought into emergency and that part not being accepted by the family. There are patients who come in walk-in saying that I have an acidity, and I would really want to discuss this one case here, which I would like to highlight. In today's era, the challenges which technology has got into us. Okay. We get a patient who has come with MI. He came walking to us stating that I ate chole bhature in my dinner and I'm not feeling comfortable. Fine. He was brought into emergency. Sorry, it was lunch, and he was brought into emergency. He was taken care of. We did an ECG. The first question arrived was for the acidity patient. Why are you doing ECG? After explaining that why an ECG is needed, they agreed. In the ECG, it turned out to be a massive heart attack, and the patient's BP is not recordable. Okay. Now the patient is already into a critical zone, but he came in walking. So the attendants and the patient had a very difficult in adjusting to the fact that the patient has a problem. Based, and this happened right in front of our eyes, based on this information, while we are discussing the outcomes and the further management process of the patient family and the people who are the moment they heard heart attack, there were 5 people I still categorically remember, and 3 of them dispersed out behind on their phones. 2 minutes later, one guy comes and says, "No, you're trying to make money out of us." He does not have an heart attack. We have multiple cases documented. I have just searched the internet. I said, fair enough, but why is his BP not recordable? So we tried to counsel a lot to the patient. Ultimately, the patient decided to go against medical advice. We arranged an ambulance. The ambulance with the doctor is standing right outside and they refused to take it. They took the patient in the car. They reached the hospital, but the patient was declared brought dead there. Right? So there is a mortality and morbidity which is associated with the decision which people are taking based on technology. We should use technology. We are not against it, but the right method needs to be incorporated. I think it is the right time when we should think ahead of times. This is going to be a common scenario. And when there is going to be a dilemma or doubt, how we should arrange for other opinions for the patient, how we can discuss out to them and how we can make them understand is very important. This is the patient's perspective. Other scenario, we have critical patients going on, CPR is going on. Many a times, by the time the doctor goes out and informs, so the patient could not survive. Many a time they are not able to take that news, and we have heard because of that particular incident multiple times there have been a scenario or a difficult scenario where the safety of the patient as well as the medical staff has been compromised. We are not discussing about the safety of the whole system as such, but what my focused point is that when we are talking about patient safety, once the patient arrives, the communication is the key to handle such situation. And early indication, early involvement of the patient's party at the bedside, letting them know what is happening to the patient, reduces these kind of incidences by half. Okay. So with that, I would like to also make sure that at present, most of us, we know what challenges the hospital and the administration faces when it comes to the statement stating that we need to have uh, more people who are experienced and trained in that field. Okay, so training and upbringing of such medical personnel in the field of emergency is also very important. Having freshers taking care of it is definitely going to produce more challenges. Okay.
Thank you so much, Dr. Divya. We heard Topsy talking about her concern related to connecting with the patient, connecting with the family members, the importance of eye-to-eye contact, the attendant to be taken care of, providing them with a proper, seating area, the emotional connectivity which has to be there, acknowledging the patient, the family members. And then Dr. Divya also talking about sharing her experiences, the importance of proper history, importance of communication, the proper communication, and some of the challenges which are faced. We'll come back to both of you, but now we would like to go on to Vipin, hearing from our patient Topsy and are Dr. Divya. Vipin, you are preparing the nurses to work in emergency when they join the institution. And of course, in-service education also continues. So
Yes.
looking into all this, please share, how do you prepare them to take up these responsibilities? Over to you, Vipin.
Thank you, Dr. Kalra, for giving me this opportunity. And at the outset, I'd just like to say it's an honor to be a part of this distinguished panel today to discuss such an important topic, which is engaging patients and families in emergency department. Now, as you know, as the discussion is going, that engaging patients and their families is really crucial for ensuring patient safety and delivering high quality care. In our hospital, we employ several strategies to enhance staff knowledge and skills to facilitate this engagement. One of those is actually using simulation-based training. I'm a huge proponent for using simulation-based training because you can create or recreate emergency scenarios, and this helps nurses and other healthcare staff, to practice their communication in a very safe environment, in a controlled environment. And so, for example, you could create a cardiac arrest scenario, and you could have the nurse communicate clearly with both the patient's family as well as the medical team. We also conduct a lot of workshops, communication workshops for empathetic communication. Here, nurses and doctors are given opportunities to practice as in role plays. So this again enhances their communication skills, their empathy, and their confidence in handling skills in real life situations. Another thing that I would like to emphasize is, in terms of patient engagement, is some techniques. Like one of the techniques that we teach our nurses is the teach back method. So whenever nurses are, nurses are actually trained to use the teach back method when they are teaching patients or their family members any healthcare concern. Like, for example, whenever they share any information, they can check for the patient's understanding or the family member's understanding by checking through the teach back method. That is this not only enhances their understanding, but also ensures the compliance to the treatment plan. So this is really, really important, especially during discharges. And also when you're teaching the patient about their diabetic regime, their thyroid regime, and things like this. So teach back method is another important tool that we are using. Another thing we train our nurses to communicate in is by using simple language. That is, we focus on using simple language and not use a lot of medical jargon. I give a small example. Instead of saying, that your patient's having a myocardial infarction or something like a cardiac arrest, it's very simply told that, that your patient is suffering from a heart attack. And so the language that the patient understands. So that is another focus. As Madam Topsy has mentioned that, families need to be, or as an attendant, they need to be informed about the patient's care. What we train them is also for having these family meetings, especially in the emergency department. As Dr. Divya also said, there are counseling rooms which are present. So we have those in our hospital, where we conduct family meetings. So these are scheduled, or they could even be without a schedule, where the emergency department doctors actually keep the family members notified of the patient's problems. And this helps the family members to be involved in the patient care. So that's another important thing. And also, what we do in our hospital is we have these educational materials made, using audio visuals, or these are videos, or these could be brochures which are shared with the family members regarding diabetes or hypoglycemia management, or if so when they are discharged from the hospital or even from the emergency, they are told about the symptoms of, suppose if a patient has come with some signs of stroke, then the family is educated on what are the signs and symptoms of stroke and what they need to know about those things. So educational materials, providing them with this, is also helping and engaging with the family members, and it shows good outcomes. I second with my opinion with the opinion by Dr. Divya, as she's saying that, as she just said that, healthcare is evolving. And I would like to say that, yes, it is evolving. So initially, we used to focus a lot on patient satisfaction. Then still patient satisfaction is having a high metric. But then we have now moved slowly to patient experience. And now the next part of evolution that we are going through now, there's a lot of evidence-based practice which suggests that patient engagement is of great importance. So this evolution from patient satisfaction to patient experience and now to patient engagement. The reason we are focusing on patient engagement is because it has shown that it can really help us reduce errors. So it's actually enhancing patient safety, because patients are involved in their own care. So they are making good decisions. So they're able to take decisions. They are contributing to the kind of care that they are expecting from the hospital. And so these are the most important things. I'll just recap on the important points. That is, for training nurses in corporate hospitals, we use simulation-based training. We have workshops where we are training them with role plays on empathy and communication, using teach-back methods, using a simple, plain language for communicating with patients and helping them understand their condition, involving the family members, and especially, as Dr. Divya was mentioning, like, for example, during a cardiac arrest, it's really, there is literature which is actually showing that having family members present at the time of the cardiac arrest, especially in the emergency department, really allows them to understand the condition of the patient. And so instead of having them in a room outside the ER where they're just wondering what's happening with their patient, actually allowing them, maybe a more mature member of their family, to come and witness. And the nurses actually can say, so what we train also is we tell the nurses not to say things like, don't worry, everything's going to be all right, or ghabraiye mat, sab theek ho jayega. No, that's not what they're supposed to say. What they're supposed to say is, our doctors are doing their best, and we have our team is the best. They're doing the best they can for the patient. So those things are not giving any false promises to the family. Rather, it's actually keeping them well informed, and using tools like, this is another thing, that using tools, we always think about ISBAR, which is introduce, identify, introduce, tell the situation, the background, assessment, and recommendation. We normally think of ISBAR as a tool that can only be used with healthcare workers. But no, you could even use ISBAR and tools like AIDIT for communicating with patients and their family members. So, giving them just the situation, what has happened to your patient, what is the background, like he's come with this heart, he's come with this chest pain, and the assessment is on the ECG that we've seen this, the ECG shows that he's got a mild or a major heart attack. And what is the recommendation? Now we think that, we might have to admit the patient or send him to cath lab for a procedure. So, using the same tools that nurses already use in their day-to-day practice, like ISBAR and AIDIT, for communicating with patients, can be utilized even for communicating with family members. So that's about how we educate our nurses, ma'am. Dr. Kalra, over to you.
Yeah. Thank you so much, Vipin. You talked about simulation-based training. You talked about the importance of communication, the training that you're giving in them, teach-back method, check the understanding, what you said, how much the person is able to really comprehend. Because many times when we use a lot of medical jargon, we take it for granted because they become a part of our practice. But a patient who may be well-educated may not understand these terminologies because this specialty is something different. By training the family members is very important. Keeping the family members notified is very important. Patient satisfaction, how it is moving, the assessment from patient satisfaction to patient experience, and now talking about patient engagement, which is what we are discussing also today. And this will definitely help to reduce error. Yes, people have to really look into the possibility of involving the patient into CPR. Certain policies have been made. If we have now the patient attendant for in the labor room, we can definitely have a thought and discussion with the policymakers to look into this also. SPR tool that we are using for in our nursing can be also used for the family members. Thank you so much. We'll come back to you. Now we go on to Colonel Sandhya. My request, Colonel Sandhya had been an emergency nurse and a nurse as a nursing superintendent, heading the training department also. She also has faced many challenges. Over to you, Colonel Sandhya, to share your experience and your views.
Thank you, ma'am. Actually, as per the views of Ms. Topsy, Dr. Devya, Mr. Vipin, I mean, absolutely correct. They are all, I just have to only lining up that it should be 4-5 criteria to improve your emergency department, to create a better patient experiences, that is to improve the efficacy of the frontline healthcare workers. So, and then you to reduce the patient, the workload, the paper workload, to introduce more of a digitalization. Third is that to have more of advanced biomedical equipments and their training to the healthcare workers over there. Fourth is that the use of technology, as I've already told. Fourth is that a nurse or senior nurse who is a bit of proactive, who is a competent, can be chosen as a duty manager to solve the issues of the patients with the relatives. And whenever there is that, a proper adequate manpower management, which include your nurses, your doctors, your security managers, and a pure intradisciplinary coordination. Because you should be knowing a patient comes on stroke, there is a door to needle time, you should be taking time to the CT. So that's time. So there should be a proper intra-departmental coordinations. And finally, the time, I'm not wasting much time. So finally, the time we should be realizing that we should be knowing about nurse practitioner in emergency care, because it actually will reduce the workload of doctors and actually patient experiences. Because as I was going through, there's a study of impact of patient outcome by the National Institute of Health, that if an organization have all that have created a well-developed, defined emergency, there is an increase of 37% of increase in patient outcomes, 28.1 degrees in reduced patient deaths and mortality, and 18.7% is degrees in complications, and 15.6% is improved recovery. So we should all, when we plan a thing, it's not the nurse only, it's a multidisciplinary factor in emergency. And personally speaking, as an organ donation advocate also, if you see, we have found out there is an evidence-based study. If a patient experience in 4 hours in any of the hospital, the patient experience good, the entire journey of the patient outcome, experience, everything gets changed. So the patient has a very bad, or the attendant has a very bad hassle in the emergency, his total opinion of the organization goes bizarre. The whole is hospitalization. Hello.
Yeah, thank you, Colonel Sandhya. I feel that you have said very valid points, that efficiency of frontline worker is very important. One really needs to focus on improving the emergency department, because that's the face of the hospital. The first experience of the hospital, most of the people may land up in emergency and then assess how good are the services being provided, how efficient are the people. And definitely, we also need to look into the intra-departmental coordination, inter and intra-department coordination. And if the roles are very well defined, who is going to do what in emergency, then it becomes much easier. Because if the roles are defined, even during disaster drills and disaster when it happens,
Yes.
when the rules are defined, it becomes easier. There are people
Yes.
to talk to the family members.
And forgot to mention that the nurse the nurse should be knowing about the MLC, medical legal implications in emergency, because that's the main thing we actually,
So very
because we,
valid
the
point, Miss
deployment is
Andrea.
also, the deployment of nurses should be such that they actually goes of a awareness on medical legal implications in emergencies.
Yeah, rightly said. We'll come to Dr. Divya, but before that, we'd like to hear from our patient Topsy also, that after hearing from all of them, what are your views?
One thing I would definitely like to mention, though I've written in the chat box about what incident that Dr. Divya had mentioned, that when a critical patient came and he was declared, I mean, after some time he didn't survive. So, and then it was in the safety of the doctor and probably the nurses, the family members, how they react. So with such critical patients, now you see what is the first impression when I am coming to an ER, right? My first impression is I'm already down mentally. Physically, let's forget. Mentally, I'm already down. My attendant is already hassled and worried, to get me on time. Now he's got me to the hospital. Now, the first person who's meeting me, right, or who is taking me in should be, what should I say, soft, kind, have a listening ear. Of course, it has to be very fast because I've come to an emergency. I may be very critical or may not, right? And very fast. But while taking me in, at least can start, with the basic, take a brief of what has happened instead of first putting them on the bed and then understanding, right? So that connection immediately starts and you're being soft with them. So, how polite, how soft, how emotionally you connect with a patient helps a lot, because then I feel I am in safe hands, right? I have come to the right place. I will be fine. So, mentally, somewhere at least 2-3%, I'll be stronger, right? Because I have had that emotional connect. She's listening to me, she's understood my problem, whatever the problem, but I am satisfied. That first connect is very, very important. So, like, of course, I can understand in an emergency room, you don't have so much space and you can't have attendants everywhere, So, of course, with very critical patients, at least, if the attendant has come in, now with the others, you do send them out, right? After you judge, you can tell them, please wait outside. But a very critical patient who, for that person, you could have the attendant inside so that the attendant can also be there present to see what is happening, proper action is being taken, because he's not, though he may know, but mentally you're never prepared. Okay, my person will go. Because the relative is only bringing, either the son will bring the mother or the mother will bring the child. It is very close relative that will bring. So that person can be there inside with the patient. For very critical patients,
I
because I
would
can
say this,
understand,
Bhatia.
short of space.
Yeah, no,
Yes, over to Dr.
I
Divya.
am of
Rightly
the
said.
opinion, Miss
Yeah.
Bhatia. Yeah, I'm of the opinion, Miss Bhatia, that from the emergency perspective, after practicing for 15 years, I am definitely of the opinion that one attendant should be there with all the patients. There are multiple reasons why we come up with this plan. One is because emergency is a place, as I told you, I might have 5 patients, I might have 50 patients inside. Okay, my strength of the doctors and the nurses are still going to remain the same. I am expecting it to have a surge. My strength is going to remain the same. So my same 15 nurses, say if they are there in the emergency department, those same 15 nurses, 3 doctors are going to deal with 5 patients and 50 patients.
Yes.
So if I have an attendant by the side of the patient, I am more comfortable because I'm pretty much sure that the whole sequence of events of the patient is very clearly verbally put into the mind कि मैम ये हुआ था. Okay, there is no misses. All the adverse events many a times can be picked up if a proper history is taken, a proper communication is established. Okay, so when we say about having an attendant inside, I completely go by that. Yes, we should have an attendant inside. Precisely one attendant policy should be there, which is what we have also adopted in Holy Family. We keep one patient, one attendant, that's it. Okay, but apart from that, more than that, my emphasis on that incidence was the technology driven half information. We have learned this over years. Half
That
information
I
is a
agree.
dangerous thing. Right?
Yeah, so
So
that I
that
agree.
part, the use of technology is so bizarre at this point of time. There is no focus on what we are going, where we are landing. And the decisions are made just by one search Google tab or say an internet access. That needs to be this is not going to stop. I am not saying it should be stopped. It cannot be stopped. If I am the attendant of my patient, if I am the attendant, I might also land up in a trouble, and maybe I'm not aware about that particular incident. I might also refer. My reference will be of different style, different kind, because I'm from the medical background, but I don't expect patients to have the same reference. For them, the easiest reference available is the net link which they go through, and they make their decisions. So what, as Mr. Vipin said earlier, that you should have those tools and brochures which helps them guide. They have taken a decision, we explain them, they have understood, but a visual concept of and making them understand will be much more helpful, and to make sure that the patient outcome is better. See, ultimately, all the hospitals who have made an existence right now in India or worldwide, they all have mission, vision, setting goals, objectives. Those are all related to the patient's safety and patient's outcome. All those things are for the patient's outcome. So patient's engagement definitely has to be at a very beginning level, so that the patient is also aware what is happening with me. At times when the patient is in too much of pain, not able to understand what is going on, having an attendant by the side helps us to calm down the patient, not only help in bonding with the patient, but also coming to a better diagnosis for the patient. I'm talking from the completely medical perspective. So, today's world, all the organizations have come up with a plan of giving a reliable care, which is the right of the patient, which should give professional, medically, ethically right care, making sure it taking care of the legal aspects, financially viable and scalable. We all have to look into all those zones, which definitely is not the shortcoming of the Western countries. But that here, a lot of things are dependent on the financial issues, and obviously making sure that there is no misuse and or abuse of the healthcare services which are being provided, which we all know, because patients are not aware. The awareness is very minimal. For every smaller larger thing, patient do come, as you said, that it is mainly when they come and when they have a first discussion. So we also land up with patients who come, which has happened some 2 years back. They start from 2 years back problem. I can't say, you tell me what has happened right now. So I just ask them very politely, can you tell me what made you come to the emergency today? Why did you think you should visit emergency and not go to the OPD? They come up with an answer. So that is one way of establishing communication, one way of acknowledging that, yes, I understand what you are having through this time, but what made you come to the point that helps in diagnosis. So that's where Mr. Vipin said that we need to have a better, skill labs, simulation center. Now it is up to the government management to make sure that the brain drain doesn't happen. I mean, that's another level of challenge which the whole country is facing. So I'll not be commenting on that. But yes, we are here to develop a better care. So we should be focusing on that. And with your opinion, I guess it becomes much more easier with the actual scenario and actual issues being faced, then it is just not a discussion which the panelists are having. So I'm really grateful that you took out time and you came here, and I had been a part of a discussion which looks more of a real discussion. Thank you.
so
Thank you,
much.
Dr.
Yeah.
Divya. It has been really pleasant hearing from Topsy, from you and all the panelists. But I'll again go back to Vipin for his final, what you want to say after hearing all other speakers, all other panelists. Vipin?
Oh, thank you.
Yeah.
Yes, ma'am. Yes, thank you. Thank you, ma'am. Ma'am, for me, what I've gathered from this a great discussion actually is that patients really need to be, engaged. And in order to do that, actually listening to what Madam Topsy was saying, is they need to be acknowledged. Not only patients, but also their attendants need to be acknowledged. And this can be done through various ways. But then, yes, giving that, something that is doable is, listening to them, actively listening to them, making sure that you have an eye contact, and then you understand their problems, and then take a shared decision. The doctors inform the patient attendants, the patients, and the patients actually understand about their condition. This engagement actually improves their satisfaction, improves their experience of the whole the hospitalization process, which is not easy for any patient. And developing this trust actually happens through clear communication. I think what I took most from this discussion is that everybody needs to have a good channel of communication where the patients are feeling that they have been heard. The doctors are able to communicate properly. The nurses are a part of the communication as well, and obviously. Again, leading to the management, how the management focuses on the engagement of patients and the family. So there's a lot of new tools also that are being used, as Dr. Sandhya ma'am was saying, about the feedback tools that are being used in so many hospitals. So that's my take, ma'am, on this topic.
Thank you so much. Thank you so much, Vipin. We definitely agree, and we all feel that yes, the one and the most basic thing is communication. How you communicate, even when it is that people going and searching from the Google. If you have a healthcare professional who says, if you have any doubt, come back to me, I'll answer. Fine. At least even if the person has searched, looked into, comes back and discusses, this is what. So for that, you need to have, if like said, if you have a counselor, that's the best one, because maybe the doctor and the nurses might be busy, or a specific person assigned, could be a nursing person also assigned, a senior nursing person to coordinate and look into that, yes, if there is anything, I'm the first person there available to look into and reply to the queries and answer them. When the connectivity, what when Topsy also said, that has to develop, and that should be from right from the time that the patient has entered the emergency department. The connectivity with the patient and with the family members is very important. Now, to Colonel Sandhya, your final statement, hearing everyone. Colonel Sandhya?
Sandhya need to unmute. Sandhya need to unmute yourself. Still not okay.
Colonel
For
Sandhya,
me, there is
please.
only one statement that
Yeah.
the first impression is going to be your lasting impression. So the first person, and how do you treat your patient, how do you interact with your patient, that's the impression they are going to last the entire hospital or the entire hospital experience for you, your own organization, and your totally your house. So that will be always leaving an imprint on them. So to mark an example, I was to take, it's my own example. Like I had found, we had a brain death in one of our hospitals. So we just went, he was an young patient, but thing is that the relatives was not willing for the organ donation. For one thing is that my patient was in emergency for almost an hour and nobody looked after. So why do you have to help the organization or other people? Because if somebody would have, maybe the patient, it's not that we would not have taken care of it. It must be the thing, he was a stroke patient. So they were getting ready for the MRCT or something, but nobody conveyed this to the attenders. So they thought the patient is lying like, and nobody is attended. And that grudges or that negative impact made along, and then they had a very bad impression to their own experiences in the organization.
Thank you, Colonel Sandhya. Yes, there's a great message that the emergency department has to improve, communication has to improve. We need to engage the patient and the family members. We need to ensure that our emergency department provides reliable care, ethically and medically safe. There's a shared decision making. It is not that we take the decision and we do this, but shared decision making with the family and caretakers is very important. And we need to look into that our patients and family members are satisfied with care that we are providing. And even as a nurse educator, when we teach the nurses, the first class that we have for our nursing students is on communication. The first day when they go into the clinical, they have a discussion on communication. We demonstrate to them how to start your conversation with the patient, how do you communicate, and how do you maintain throughout. Even if you are a beginner nurse, novice nurse, but that one communication, even if you do not know something, just telling the patient, I will just confirm and get back to you. That's very important. So communication is something which is very important. I think it had been a wonderful discussion. My special thanks to Madam Topsy, who was a central part of discussion, and really your things were very, very valid and an eye-opener also. Dr.
Thank
Divya,
you.
also thanks to you for sharing your experiences, because when you share our experience, it is really a lifelong learning, because it always remains there. Vipin, thank you to you also, because with your vast experience as a nurse educator, you focused on how we all as nurses can train our students and our novice nurses and those who are already there better to be working in emergency. And my thanks also to Colonel Sandhya, who shared her experiences as an administrator, as an organ transplant nurse, and also as an emergency nurse, administrator, taking multiple roles. Thank you all to you. And my special thanks also goes to Madam Tangam Mumiz for providing us with the link. Now, most important is thanks to all the ANI executives, and special to Dr. Unmona for giving this opportunity to us. We had a wonderful time taking this discussion, and my also thanks are due to all the participants. We have our students also sitting in groups, the post-basic and MSc students, first year, second year, they're all sitting in the group with one link and attending. Thanks to you also. Over to you, Dr. Unmona.
Yeah, thank you very much. What I can say, it was marvelous and intense in the depth and everything I can say. And Dr. Divya really brought up the situation. It is really painted in my mind forever, probably, how the family expectation. And when I'm thinking what can be done for this. When I attended the Singapore General Hospital in the emergency department, they have also written that you cannot blame me. What you want, you tell me. We are doing our best. Kind of information from our side also we have to communicate to the people, and every time we ultimately become the victim. Why we become victim? By nature, because we also wanted to save them, we could not save. We feel that, but after doing so much, if we are not able to save the life, what to do? It is a God's will to take them away from us. It is something like that. But it is really wonderful to have the Madam Topsy, such informative, sub-educative discussion that we had, and we also took a lot of points. And yes, of course, Sandhya and Bipin add to many of the points that we have to take back home. Yes, Madam Raminda Kalra, you have done marvelous, and I congratulate you. I thank you from bottom of my heart, because in the last minute, within a very quick time, that you have got this marvelous people, and we had the marvelous discussion. And that's all. And I wish if there is any particular question from the participants, they can ask to them. Anyone can just put on their audio, and video can come. If there is no question, that's all right. And particularly to tell about, and after intense discussion, and we have completed on time. That is wonderful. So
I would just want to say a very, very big thank you, Dr. Unmuna, Dr. Raminder.
to you, ma'am, first and foremost, you have done the
No,
marvelous thing.
I sometimes I just take the role of a facilitator, but how it is executed is very, very critical. So special thanks to Dr. Raminder putting it all together, and very, very special thanks for bringing in Miss Bhatia here, because truly, truly, she's the voice of the patient and the attendant, and her discussion led to thought-provoking, discussions with the other panelists, Dr. Divya, Colonel Sandhya, and Vipin. And it's really, really very engaging. And thank you so much for keeping up the vision of, Association of Nurse Executives India, because we say that we embody and work towards patient safety. and towards no harm. So finally, by engaging patients and relatives, we are committed that we do not harm our patients. Thank you so much. And thanks, Dr. for putting it all together. Thank you very much.
Yes, ma'am. Thank you. Thank you to everyone. We can wind it up probably.
Thank you.
Thank you, ma'am.
Thank you. Thank you.